A warm welcome back to the 2021 Virtual World Cancer Leaders Summit. We're going to move on to the last session of today now, a facilitated focused dialogue on potential health systems innovation to improve cancer care and to address inequity. Now, in this session, we'll hear the findings from two recent Lancet Oncology commissions, one on advancing equitable access to diagnostics and one on medical imaging and nuclear medicine. And we'll also hear from one of the speakers about innovation in cancer from the viewpoint of a cancer research organisation. So with that introduction, I'd like to welcome our last three panellists of the day. Professor Sue Horton is Professor of Health Economics at the University of Waterloo. Professor Rifat Atun is Professor of Global Health Systems at Harvard University. And Michelle Mitchell is Chief Executive Officer at Cancer Research UK. Welcome. Thank you to all of you for connecting with us for today's dialogue. Just a reminder to all of the leaders watching as well, at the end of the session, we will have a Q&A. I invite you all to pose your questions, submit your questions in the live question forum on the Summit platform, as you've been doing so wonderfully throughout the course of the day. So let's start with Sue Horton. Sue is, as I said before, Professor of Health Economics at the University of Waterloo in Canada. Sue, it's wonderful to see you. The report, first off, of the Lancet Oncology Commission on Diagnostics was released earlier this month. Tell us a little bit about then the overall situation with regard to access to diagnostics.
Sure. So our report came out with 7 key messages. Okay, and just let me mention, it's a Lancet commission rather than a Lancet Oncology. So we were not focusing only on cancer. But the key message that really shocked me was how poor access was to diagnostics. And the headline was that 47% of the global population has little to no access to diagnostics. And that's partly because some of them live too far from a health center to be able to readily access care. And we define that as 2 hours walking distance. But then also, even if they walk all of that distance, even if the health facility is supposed to have diagnostics, frequently they are stocked out or just not available. And that situation is even worse for imaging, which of course is tremendously important for cancer. And I'll mention very quickly the other findings. So one is that diagnostics has been neglected. It's kind of the ugly sister in the Cinderella story that, for example, in the SDG 3 on health, which mentions medicines 4 times and vaccines 3 times, there is no mention of diagnostics. So it comes from the top. On the other hand, at least the COVID pandemic has really underscored the importance of diagnostics, and perhaps that will help us to make this situation better. Also, the technology is making things easier, point of care testing, etc., to drive diagnostics down to the primary care level and to improve the amount of equity. And finally, there are huge benefits if we can invest in diagnostics. So our calculations in the report are that 1.1 million annual deaths could be averted if diagnostics were improved for 6 key conditions in the low and middle income countries. Okay, that does not include cancer. So the actual number is higher than that. And lastly, that the economic case is very strong. That for each dollar invested in diagnostics yields up to $24 in benefits.
So is it overly idealistic to imagine that innovation, where there's innovation in the diagnostic space, that will ultimately address all of these inequities that we're talking about and could actually really reach those who need it most?
Yeah, so I'm a kind of good news, bad news person, and I personally like to get the bad news over and done with first. So the bad news is that, yes, the companies that dominate the market in diagnostics globally, if we think of the top 4 companies in each space, they are all from high-income countries, and so they are dealing with cancers that are appropriate, that are common in the high-income countries, and technologies that are readily available, and resource levels that are really different. So the statistics are that in laboratory diagnostics, more than half of them are produced by only 4 firms, and 75% of the medical imaging equipment, again, by only 4 firms. So the good news is that international organizations have stepped in and have focused efforts on research for diagnostics which are appropriate for low resource settings, with less technology. So I'm thinking of organizations like CHI, the Global Fund, FIND, the Foundation for Innovative New Diagnostics. And also we see efforts in the regions, like in Africa, quite recently, they've really stepped up this idea of decolonizing diagnostics, producing more locally, doing more research and development locally. And those things will be good for equity.
And specifically on cancer diagnostics as well, what's the main thrust of your advice when it comes to addressing these sort of equity challenges?
Okay, so I think there are lots of angles on this. One is that with universal health coverage, we have an opportunity to enable poor households to have access to treatment, but they also need access to diagnostics. So if the universal health coverage package covers a particular illness as far as treatment is concerned, it must also cover the diagnostics. Otherwise, what you will get is that rich people pay for the diagnostics themselves out of pocket, and then get access to subsidized treatment. I think another issue is you have to think of the whole system of healthcare. Some countries have really wonderful cancer centers, but not necessarily the links to the hospitals and to primary care that will make for success in reducing cancer deaths. At the primary care level, you have to train health workers to recognize signs of cancer and refer people for testing up to the next level of hospitals. And also you have to equip district hospitals with basic things for doing blood chemistry, without which you can't safely administer chemotherapy, and also with hematology analyzers such that you can safely do surgery. Okay, and one very quick thing I'll mention is when we're thinking about equity, we also need to think about very vulnerable groups, such as those in fragile and conflict situations. Mm-hmm. So, here in the Middle East, for example, the King Hussein Cancer Center will take and treat refugees and will diagnose and treat refugees and displaced populations in the region. And we need more of that.
Okay, well, for now, thank you very much, Professor Horton. And stay with us because, as ever, we've got our Q&A at the end, and I'm sure there'll be some questions for you. But our next speaker is actually in Boston. Professor Atun is Professor of Global Health Systems at Harvard University. Welcome to you, Rifat. I'm wondering, we just heard from Sue about the Commission on Diagnostics. I'm wondering if there are similarities between that and the Commission on Medical Imaging and Nuclear Medicine.
Absolutely. Many of the principles do apply, although the challenges are slightly different, as are the solutions. First of all, we looked at scaling up imaging diagnostics, different kinds of imaging diagnostics, sort of a traditional package plus an expanded package with more advanced technologies, along with the scale up of radiotherapy, surgery, and chemotherapy, plus improvements in quality of care. And what we found was something very important. First of all, there are benefits to increasing each of those components separately. So large benefits of increasing imaging diagnostics and access to them, large benefits to increasing surgery, radiotherapy, and chemotherapy, large benefits to increasing quality of care. But when these are combined together, there's a synergistic effect. And the benefits realized are far, far larger. For example, increasing imaging alone, this would save around 2.5 million life years in the period 2020 to 2030. Scaling up treatment alone, the three modalities that I talked about, would yield 4.1 million savings in terms of life years saved. But combining all of these with quality of care, a comprehensive scale up would lead to would projected savings of 9.6 million life years saved, amounting to around 134 million life years saved in this 10-year period. And the returns are very substantial. What we estimated was that the cost of a scale-up a comprehensive scale-up, which is the desired approach, is around $230 billion over a 10-year period across 200 countries. This is not a large amount, given that this is over a 10-year period across so many countries, and would mean an increase of around 6.9% on the current expenditure on cancer in low and middle-income countries. But the benefits using what we call a human capital approach, the productivity gains from the life saved and individuals being able to go back to work are very substantial. 2.7 trillion net benefits. So for every dollar invested, one gets a return of, in the context of Africa, $21.4. In the context of Asia, for every dollar invested, $40. And in Latin America and the Caribbean, almost $80. And every country benefits. So there's no excuse for not scaling up these interventions in a comprehensive manner.
Yeah,
but,
the maths
but for it to be successful, we need health systems.
Yeah.
They need to be functioning.
Professor Atun, I know you've been involved in several commissions, including one on childhood cancer. And so with that in mind, I'm wondering what commonalities, if any, that you're seeing across different commissions, and how do you actually move forward then with the recommendations of those commissions in implementing them and actually seeing them come to fruition?
Yes, so I had the privilege of collaborating in several commissions and leading three. One was on childhood cancer, a commission on sustainable care for childhood cancer, and another one on radiotherapy, scaling up of radiotherapy. And what we've been able to demonstrate, along with the Lancet Oncology Commission on Imaging, is that there are very substantial health benefits and economic benefits. So for the first time, we're able to show the magnitude of these benefits over time. But what we're also able to show is that one is able to incorporate these interventions into universal health coverage benefits packages. So that should be possible. And the scale up is affordable because spread over a long period of time, over 10 years or even longer, the incremental cost is not very large. So now we have a very clear investment case for scaling up cancer services for children, for adults, and using necessary modalities, surgery, radiotherapy, chemotherapy, as well as imaging diagnostics.
And what kind of investments then do countries need to make? I know there are lots of questions already coming through from the audience as well about the money side of it. But from a country perspective, what kind of investments do they need to make?
I think the most important message is that we need comprehensive scale up. Scaling up one component will not yield the desired results. So that means investing in health systems, strengthening human resource capacity and training them, especially in a multidisciplinary manner. Secondly, ensuring that there are new service delivery models that are able to bring together networks of providers. Thirdly, scaling up technologies together, so diagnostics, surgery, as well as radiotherapy and chemotherapy. Mm-hmm. And finally, investing in approaches that will enable lesson learning, enable development of local solutions to local problems, not importing solutions from elsewhere.
Professor Atun, we hear a lot about innovative financing, sticking with the money theme again. Is innovative financing just another sort of buzz phrase, or are there really examples of ways that resources can really be generated to support cancer and care?
Yes, I mean, given the very large health and economic benefits of investing in cancer prevention, care, and control, there's a compelling case to invest and fund this appropriately. And money will need to come from multiple sources, from the sort of tax revenues that governments generate, from targeted taxes such as tobacco tax or tax on sugary beverages. One could reallocate funds in the health system to more cost-effective interventions, and also from innovative financing such as social impact bonds or development impact bonds, because there are very substantial returns to be gained at country level. But all of these sources need to be combined together to enable application of funds to scale up cancer prevention, care, and control. So innovative financing is a critical additional component.
Okay, and I'm sure we're going to hear more about that through the Q&A. Rifat, Atun, for the moment, thank you, but please do stand by. I'm going to move on to speak to Michelle Mitchell now. Michelle, normally you're in London, but I believe you're not right now. But you are still Chief Executive Officer at Cancer Research UK. I'm not sure the connection to you is all that strong, which is why we're just going to see a lovely image of you, a still image, rather than you sort of moving around, as it were.
I'm delighted to be with everybody regardless.
It's wonderful to hear you. First off, what have been the biggest innovations in prevention policy in the UK, say in the last decade?
Thank you. 4 in 10 cancers are preventable in the UK. So there are huge gains to be made by finding innovative ways to help people reduce their risks of cancer. The UK has been actually at the forefront of exciting new prevention regulatory measures more recently, in particular tobacco and obesity. And it might come as a surprise that the governments that have led this work wouldn't necessarily be the ones you would automatically assume would naturally support a regulatory approach. So to give you 2 examples, on tobacco in 2016, actually after a long campaign by CR UK, the UK became the 2nd country in the world to mandate standardised packaging for tobacco products. On that same day that standardised packaging became mandatory, the UK also introduced a minimum excise tax, which set a minimum price for factory-made cigarettes and helped enhance the effectiveness of standardised packaging. Now, through CR UK funded studies and other sources, we believe that those regulations seem to have effectively helped to reduce the perceived attractiveness of cigarette packs amongst younger people, enhance the salience of health warnings, and led to increased prices and reduced tobacco sales. So decades of comprehensive policy action has meant adult smoking prevalence in the UK in 2019 was at a record low at 14.1%. But of course, this masks quite significant inequalities, and difference in smoking rates still make up one of the leading drivers of health inequalities, responsible for half the difference in life expectancy between the lowest and highest income groups in the UK. We've also been at the forefront of really making connections with the public and policymakers on the issue of obesity, publishing relevant research, and importantly, urging government action, as being overweight and obese is the 2nd biggest preventable cause of cancer in the UK. So we worked with advocacy alliances to help create a policy environment where we believe policy innovation could flourish. The UK has not 1, but 2 claims to the world-leading policy innovation, the soft drinks industry levy and junk food marketing restrictions. The levy, the sugary drinks tax, was implemented in 2018, but before it was even introduced, over 50% of manufacturers had reformulated their drinks. So we believe the impact has been significant. Sugary drinks have seen over 10 times level of sugar reduction compared to other food categories, subject only to a voluntary reformulation approach rather than a tax. It's helped make the healthy choice the cheaper choice by creating a price differential between sugared and sugar-free drink. And finally, with regards to the junk food marketing restrictions, legislation is currently going through the UK Parliament and due for adoption by the end of 2022.
Fantastic stuff, and incredible stats as well. As a Brit, I can say it's wonderful to hear that lots of people have stopped smoking. It's very encouraging indeed. Let me ask you about cancer early diagnosis. I'm wondering if there have been any innovations that you've seen that have resulted in the narrowing of inequities across the board.
Well, we've put cancer inequalities at the heart of our work, working across the UK health systems and the cancer community more widely to understand the issues and influence for changes to tackle inequalities. In fact, we published a landmark report last year examining the impact that socioeconomic deprivation has on cancer outcomes. And I have to say, we found it was incredibly shocking. While cancer survival in the UK has doubled in the last 40 years, more than 30,000, that's right, 30,000 extra cases of cancer in the UK each year are attributable to socioeconomic variation, and survival is worse for the most deprived groups. At every step of the pathway, the most deprived populations have higher risk, worse experiences, and poorer outcomes than the least deprived. Now, when we look at the data that are available on cancer incidence and cancer stage, there is clear evidence of inequality, but it's not the same across all cancer types, and it doesn't always go in the direction you would expect. But this complexity isn't a reason for us not to act. And when one starts to think about interventions and innovations, we could try to improve cancer diagnosis. It raises important considerations about are the interventions going to make inequalities better or worse. One brief example, which you may find useful, is in the UK setting, is bowel screening. We know that diagnosing cancer at the earliest stages is a vital factor in improving cancer outcomes. In the case of bowel cancer in the UK, around 9 in 10 patients diagnosed at stage 1 will survive for 5 years or more. When diagnosed at stage 4, this falls to less than 1 in 10. The bowel cancer screening programme is a really effective way to catch bowel cancer early, but there's huge variation in uptake across socioeconomic groups. For example, in Scotland, uptake is over 20% lower in the most deprived populations compared to the least deprived. So when bowel cancer screening first started, particular test was used, and from early on it was clear that the differences in uptake and concerns around this precipitated various interventions to try and address the variation. So looking at the evidence en masse, a review found that a number of interventions more consistently improved participation in cancer screening, including pre-screening reminders, general practitioner endorsement, more personalised reminders for non-participants, and more acceptable screening tests. Yeah. And so on the last point, one of the key developments has been the FIT test, which requires only 1 stool sample rather than the original 6 that were asked for. In the pilot study of FIT in the bowel screening programme in England, uptake was shown to have raised across all deprivation quintiles, and the uptake in men was significantly higher than women. So some important lessons for us there about understanding the evidence that underpins cancer inequalities, and a good example of a particular innovation and a number of innovations that can help tackle inequality.
Michelle, thank you very much indeed, and stay with us on the line because I have a few more questions certainly to come to you as well, but I want to bring in the rest of the panellists as well, bring back Sue and Rifat as well, and get to some questions from our leaders who have been listening intently to everything that's being said. So first question, and perhaps I can address this to Professor Atun, to Rifat. Given the fears around spiralling costs of cancer care, how do we control the cost issue?
I think we should reframe the question and the issue. We should think about not just cost, but what are the benefits? What are the returns on investment? So if we're able to diagnose earlier, if we're able to diagnose, first of all, then diagnose earlier, the benefits to individuals and to society in terms of health and economic gains will be far larger. So I'd like to completely reframe this thinking, because we have always looked at costs. Increasing budgetary allocations to cancer yields very substantial health gains and very substantial economic returns. So these investments will yield far greater returns than what is being currently used to invest in them. And diagnosis and early diagnosis is important because in low and middle income countries, we're missing 1 in 2 children. 1 in 2 children are not diagnosed, and many present very late. Hence, the survival is very poor. Similarly, for adults, that is the case. Many cases present very late. The effect and the benefits of these innovations is actually not realized. So it's critical to rethink the issue of cost, but focus very much on the benefits.
Sue, question for you. What's the role of civil society in advocating for innovation?
So I think we absolutely need to bring in particularly patients and cancer survivors, because they can frame things in a persuasive way from their own experience. But equally, civil society organizations, action groups that, for example, advocate for reducing the cost of treatment are tremendously important. And civil society groups that work with parents to reach out into communities and to promote greater awareness, of early signs of cancer, indicating when people need to go and consult a health practitioner about something they're concerned about. So yes, absolutely, it's tremendously important.
Michelle, if I can come to you now, while we need to keep an eye on the horizon for potentially transformative innovations, are we missing a trick by not focusing on what we know works right now and ensuring equitable implementation?
I think the answer is we need both, isn't it? We absolutely have a duty to get on with implementing the things we know will make a difference now, ensuring it's done in a timely and equitable manner. But we also need to create room for innovation and research, because what we have in our current toolbox of interventions doesn't quite get us as far as people with cancer want and demand now and in the future. So we've seen in the UK in the past 40 years, cancer survival double from 1 in 4 in the 70s up to 1 in 2 today. And of course, a huge factor has been life-saving cancer research that we at Cancer Research UK and others have funded, which has developed groundbreaking new treatments as well as help us understand better the causes and the development of cancer, such that we get better at preventing and diagnosing it too. I think to your earlier question, civil society and Cancer Research UK is a charity funded in large part by the British public. We think policy and advocacy is critical too in shaping cancer control strategies across the UK, using our expertise to ensure that these strategies consider whole cancer pathways from cancer prevention right the way through to diagnosing more cancers earlier. So we need both. We need to implement, of course, what we know and invest in research and science to find new solutions for the future too.
And Michelle, you mentioned there about the changing survival stats from 1 in 4 to 1 in 2, which is obviously hugely welcome. I'm wondering, though, for the UK specifically, how the COVID-19 pandemic has impacted on cancer services and also cancer outcomes then just in the course of the last couple of years.
Well, thank you so much for that question, because COVID-19 has had a devastating impact on health systems around the world, and this has been keenly felt in cancer services across the UK. In the year from when the UK first went into lockdown, March 2020, more than 45,000 fewer people began cancer treatment than the previous year. That's a fall of 13%. And a real range of factors contributed to this. Cancer screening programs officially or effectively paused. People concerned about COVID-19 not coming forward with cancer symptoms, and an unprecedented pressure on the health system created huge delays in diagnostic and treatment services. So while there was unprecedented disruption of UK cancer services, we also did see quite a lot of innovation and rapid implementation of things, for example, innovative diagnostic tools such as a colon capsule endoscopy and cytosponge. But yes, it has had a huge impact, and we fear that unless significant investment is put into diagnostics and workforce and recovering the backlog in the UK, we could face cancer survival going backwards for the first time in a long time in the UK. So a source of much consideration, worry and focus for us all.
Professor Atun, a question for you from the audience. Given your work on different therapeutic areas, are there any innovations in the communicable diseases space that you could see being used in cancer care?
Absolutely. I mean, human papillomavirus is vaccination against HPV is a critically important tool that we have to reduce cervical cancer, which is increasing very rapidly in low and middle-income countries. Similarly, vaccination against hepatitis has been very important in reducing incidence of liver cancer in many countries. In addition, many technologies that have been used for in relation to data and data analytics is critically important for cancer, better identifying target groups, their characteristics, and how they might benefit from different interventions to transition from a one-size-fits-all approach to highly targeted interventions, technologies, but also service delivery models to improve the efficiency, effectiveness, responsiveness, and also equity of care by producing consistent quality of care to improve outcomes. So many important lessons from communicable diseases.
Okay, wonderful stuff. Professor Horton, I have a question for you from the audience. Do you have any recommendations on how to align access to diagnostics to access to medicines?
Okay, great question. So as you know, there has been for 40 years an essential medicines list, and it's only since 2018 that an essential diagnostics list has been developed. And we want those things to work hand in hand. I.e. that medicines on the essentials list should have similarly diagnostics on the essential list as well. So yeah, absolutely, those two things should be related. And also some of the policies that have been used to help make medicines more affordable, for example, by groups collecting information on the cost of treatment in different countries. We need to apply that also to diagnostics. Because those can be forces helping to make diagnostics more affordable in the resource-constrained countries.
And one more question. This is probably for you, Michelle. An outcome of COVID has been the establishment of remote primary healthcare, be it telephone or online. So do you think that this will help then when it comes to early detection of cancer?
I think it's a useful innovation. Lots of cancer patients are saying they're welcoming a number of the changes in the health system, but we have to listen to what patients want to, and it's important that, particularly at a primary care level, people continue to get the face-to-face appointments with their cancer specialists and GPs at an earlier point. So good innovations, but as always, need to be rooted in what's delivering the best outcomes and best patient experience.
Okay, well, thank you so much to all three of our speakers for this session. Thank you to Professor Sue Horton, to Professor Rifat Atun, and also to Michelle Mitchell as well, who's spoken so eloquently, even though we haven't been able to see you, Michelle, but it was wonderful to have you join the panel. Thank you very much indeed. Now, for the leaders that might have missed anything today, all the sessions will be available on demand within just a few hours' time. That's in the digital library on the Summit platform. And as we are coming to the end of the first Summit day, we will call on the participating leaders once more to engage in our last session.